Our next speaker is Dr. Dennis Turk. Dr. Turk is the director of the Center for Pain Research on Impact, Measurement, and Effectiveness at the University of Washington School of Medicine. Welcome, Dennis. Thank you.
Thank you all for being here, and thank the organizers for allowing me to have the 45 minutes that they told me that. and I am visually impaired, so I can't see that far, but I do appreciate the opportunity to speak with you. It was interesting, in reflecting on this morning, we heard Chris Feasley and Dr. Ryan sort of give the in the trenches, real world, what's it like perspective, and then we heard the big databases, large sample perspective, and I think that tension is one that's really important for us to keep in mind as we think about the kinds of things that we're going to be covering in the next couple of days, and hopefully my presentation will slip into this a bit. And I was sort of given the mission to try to actually bring this back to the individual. And we've talked about pain management, and I think that's a short term, but maybe we'd be better off talking about management of the patients who have pain, because a number of different procedures that you saw in the different slides really are very much geared toward not curing patients, although maybe acupuncture may be potentially a curative treatment, but the majority of these treatments are really symptomatic treatments, and since we're not curing most of these treatments are not curing these individuals, they are going to have lives long after the treatment's over. And the question is, what have they learned? What are they able to do that's going to allow them to continue to self-manage their circumstances over the 10, 20, 30, 40 years with which they may live with these conditions? So my mission is sort of to make you think a little bit about that. My disclosures, for those of you that want to see them, the important one is in the bottom. I am an editor of a journal, so therefore I'm biased toward RCTs and research of those kinds, but I'm not going to speak so much to that now. When we think about the kinds of treatments you've been seeing and also the other alternative treatments that are out there, there's a range, a large therapeutic armamentarium that the provider has available, from medications and the range of different ones embedded within that, surgical procedures, neuroaugmentative, nerve blocks, implantable devices, and we heard a little bit mentioned in Dan Carr's comment. Physical modalities, you've seen lots of different ones. There are complementary approaches that we've heard a lot about, psychological treatments and a range of those different ones, and including rehabilitation and interdisciplinary or multidisciplinary, depending upon how you want to use the term. So there's a range of these treatments out there that are available, and the problem is that the evidence on the effectiveness of almost any of these, as you heard, is fairly modest. I'm going to give you just a couple of examples. And this is a very busy and difficult slide to see, but I'll highlight the important thing. What it's really looking at, and this was from a large analysis of multiple studies for a range of pharmacological treatments for osteoarthritis, low back pain, painful diabetic neuropathy, postherpetic neuralgia, and fibromyalgia. And these are some of the most common and well-supported interventions. And what they looked at was the effect of the active treatment on 50% pain reduction or greater. The assumption is that that would be, at least in a lot of meta-analyses, especially coming out of Europe, that's the criteria of what success is going to be, at least a 50% reduction. And then they looked at what percentage of the people who received the placebo received a 50% pain reduction, and they differentiate between the two. So those are the three columns. And what you can see is if you look at the active treatments, they're anywhere from 10 to 50% of the patients get at least a 50% improvement. That sounds pretty impressive on the higher end anyhow. Notice there's nothing is 100% effective, as we would like to see. But if you look at the placebo responses are quite high. And then if you look at the difference between those two, the actual benefit of this range of approved pharmacological treatments heavily embedded in the literature is really fairly modest. And we've heard that reported before for some of the other kinds of interventions. But if pharmacological treatments are the primary thing that people tend to think about, and we heard from Dr. Ryan that that's in practice, that's the easiest thing to do. We've heard mention from Roger Chow about the difficulty of access to some of these kind of interventions, where from Dr. Ryan, if he was in Virginia, rural Virginia, the ability to have access to acupuncturists and to Tai Chi therapists is going to be somewhat limited. So therefore, we've got this, I'll call it the evidence-based paradox, if you will. There's the evidence for any of these treatments is modest, The evidence on the cost effectiveness of most of these treatments show there isn't a huge range of variability among the non-pharmacological treatments. But for the pharmacological treatments, it's not great outcomes. And if that's the mainstay, you can understand why we have the kinds of situation we're in. So what's the effectiveness of treatments? Well, there's no shortage of treatments. There's just a shortage of evidence of benefits. And a Cochrane review that was done in 2007 looked at 1,016 Cochrane review articles for pain management. 44% of the interventions, they said, were likely beneficial. 7% were harmful. And 49% were inconclusive. One is instantly reminded of the malign influence of fashion on medicine. More than any other science, even nowadays, it is subject to fads, although no science is more profitable. That was by Pliny the Elder in 2379 AD. So things haven't changed all that much, at least from the time of the ancient Greeks. So if the treatments are only modestly effective, and you'll notice, by the way, and I'm doing this fast because of time limits, and eventually you'll see these slides, I have citations for all these points. So if you want to look into these to see where they come from, they'll be available for you to look at. But the question is why? Why is it that we have such a range of treatments going back to earliest recorded history, and yet we tend to only have modest benefits? And that's whether we're talking about medical treatments, pharmacological treatments, interventional treatments, complementary treatments. They're all modestly beneficial for some subset of patients. So what are some of the possible explanations? Well, there tends to be an exclusive reliance on a biomedical model. And you notice we talked about, it was even embedded in what we heard this morning, it's pain management. It's not management of the person who has pain. It's managing the pain. And what I'm going to try and convince you of is part of the problem is focusing on managing the pain instead of the person who has the pain problem. And in the biomedical model, you tend to be looking for some kind of underlying occult pathology that might explain for why the difference. Those people who don't benefit just have some kind of physiological things that are going on we haven't discovered. Maybe there's some changes in the peripheral nervous system, some sensitization processes that are occurring. Perhaps the central nervous system sensitization has occurred. That's what's changing things. Maybe it's genetic factors. Lots of interest in that. We'll find out genetic biomarkers, medical indications of some of these conditions, and that might help us develop precision medicine, which is going to allow us to answer all the questions. There's also other contributing factors. How do we go about assessing pain? And I'll give you an illustration of that. We've talked constantly today about the average pain response, the average response to a treatment. And that assumes there's a normal distribution of people who respond. But it's very possible, as Andrew Moore and other colleagues have been showing, that there's more of a bimodal distribution. There are some patients who do very well and some who get no benefit. We know very little about the characteristics of who those people are. So that might explain why we see these kinds of modest beneficial effects. Maybe there's variability in sensory sensitivity. People have a different threshold for sensory information being painful for them. And therefore, it's not that it's pathological, it's just normally distributed by height and weight. Maybe there are psychosocial characteristics that are differentiating these people, and those interact with the kind of treatments that we're offering these patients. And maybe more likely, there's some combination of multiple factors that are interacting, and that if we only focus on the biological side, we're going to miss out on important things. So what are the characteristics of the biomedical perspective that might limit things? Well, pain is viewed as solely a signal of injury that's directly related to objective pathology. That's the primary assumption of the biomedical model. There's a continual quest to find the structural cause, and once we find the structural cause, we either remove it or we cut or block the pain signals getting through, whether it's pharmacological or non-pharmacological. And we try this mechanical fix of the problem, and then we provide symptomatic treatments that are just dealing with the symptom. Now, I do a lot of work with fibromyalgia. And if any of you work with fibromyalgia, what's the symptom of fibromyalgia? Well, we have a checklist of 43 symptoms in our studies, and we ask the patients, fibromyalgia patients, to indicate whether these symptoms are characteristic of their problem. The average number of symptoms in a fibromyalgia patient is 33. So we're going to have a single treatment that's going to deal with all the fatigue problems, pain problems, cognitive problems, emotional problems, and the range of other factors that these patients are reporting. So that might help explain some problems that we're seeing. The tendency is, from the biomedical model, is there's an active provider who takes over the management of the patient's pain, takes over the pain management. So either they provide a medication, or they provide a surgery, or if they're Department of Anesthesiology, do a nerve block, that they in fact somehow do something to the patient. And that's fine in a curative approach, but it's not likely what's happening with these kinds of patients. Some more challenges: patients with minimal objective evidence of pathology often complain of intense pain. Something referred to as false negatives. So what is this, a disease deficit disorder? If we could just wait around long enough, we'll find a disease. Then we have asymptomatic people who often reveal evidence of structural abnormalities using various imaging procedures. These are the false positives, or patients in waiting. If we wait long enough, we'll actually find out what's wrong with them. And just to illustrate this to you, and I don't want to go through too much time of details of this, but this is just looking at imaging procedures on asymptomatic people. And we look at lumbar myelograms, CT scans, discograms, MRI, and this is looking at the percentage of asymptomatic people who have abnormal findings that might lead someone to believe that they should have pain. But they don't. They have no pain, yet they in fact have objective evidence of pathology. So some more challenges is, if you need more, patients with the same extent of tissue pathology treated with the dental interventions respond in widely different ways, and I'll illustrate to you in a moment. Surgical procedures designed to inhibit symptoms by severing neurological pathways believed to be the generators of pain may fail to eliminate the pain in a substantial majority of patients. And let's think it's something like a knee OA, and we perform surgery, a total replacement of the knee. 20% of patients will continue to have long-term pain problems despite the fact that the surgery is performed. 80% do have alleviation of their symptoms. Often when surgery is a technical success, it is simultaneously a clinical failure. Patients continue to experience pain and disability despite the correction of the pathology. So we've done the lumbar surgery, we've taken care of the disc problem. How could that patient still have pain? Doesn't seem to fit. And finally, there's only modest correlations among physical impairments, pain reports, disability response to treatment. Knowing how much objective pathology is present in a patient is very poorly predictive of how well they're going to respond to treatment. It's going to be very unrelated or low correlation between pain reports and the actual disability. How much physical pathology does not correlate strongly with how much disability. How much pain someone has does not correlate with how much pathology. So disease and pain, are they equal? Well, they're not. They're not equal to functional limitations. Just because somebody has pain doesn't mean they have a disease, and converse, just because we can identify the cause doesn't mean we have a problem. So just an example, there's many of these, and I have to do this quickly. This is one study that demonstrated for OA patients that the disease had moderate and moderate to severe pain had little impact on the achievement of recommended physical activity levels among patients with high risks of knee OA assessed using radiographic images. And neither the disease of OA itself nor knee pain appeared to have substantial impact on participants' walking behavior in a normal setting. All right, I'm running out of time. That's my problem. So I mentioned, how do we assess pain? How do you assess an individual's pain? We've got objective information, history, exam, lab tests, etc. You've got self-reports, and you've got some kind of behavioral observation. So you could try to assess pain in each of these different ways. The trouble is, they're not highly correlated. So therefore, which is the most valuable? Which do you trust? Is it the patient report? Is it the performance? Is it the observation? Now, they talk about the variation among individuals. This is a study that Roger Fillingham did, in which he's looking at people who are healthy, have no pain-related problems. They are administered a 48-degree centigrade heat stimulus, and they asked them to rate their pain. And what you could see is the range of scores that people had to the same objective stimuli went from rating it 4 on a 100-millimeter scale to 100. And that curve is showing you the variations of those. And that's not just true in conditions of healthy controls. This was a study done by Gerbishagen et al., in which they looked at surgical responses, the same surgery, looking at the pain effects that they would observe. 179 different procedures, 69,000 plus different patients. The type of procedures, you can look down the column there. And what it's showing in the right in the bars is the pain intensity during movement or worse pain. And the bars are showing you the range. Same surgery, Same procedure for the same problem, huge variations in how it affects people's pain. So just because we know the surgical procedure doesn't mean that we know how those patients are going to respond. And the tendency that we've had is to take a snapshot view. The patient walked in the door, and you evaluate that patient. And we have a picture of that patient today. But we tend to forget that that patient has a history, that patient has experience, and that patient, if not cured, is going to continue to live with that pain. So what's it like to be a person who has a pain problem? You heard a little bit from Chris Veasley. My time is not up. We're into some interpretation of symptoms. There's an help seeking. Come on up. Diagnostic uncertainty. Tunnel vision. And what happens is, about 3 or 4. Okay, he's going to let me go 3 or 4. Okay, we started.
He's the editor of a journal. He said.
Yeah, I could do it. The important thing is, if you look at this from the interpretation to health seeking to doctor shopping to treatment to finding nothing wrong, this goes around and around. If there's one word that captures a patient, is demoralized. Their bodies let them down, the systems let them down, they don't know what to do. And pain impacts all different domains of life. I don't have to show you that too much, but just to show you the one slide that actually almost is a dose response. This is a study and looked at no pain, any pain, significant pain, or severe pain on the SF-36. That is looking at these different scales on the side. And it's showing you basically a dose response. The more severe the pain, the worse you are. So why consider psychosocial factors? I'm going to skip this one because my guy over here is going to pull me off. Psychosocial factors, as you've heard already, is affects, and these are just a few of the studies out there. There's a range from predicting disability to response to treatments to emotional response. All of the psychosocial factors I mentioned are important. So we need a new way of thinking, and there's just 2 slides. Must address and assess from biopsychosocial perspective. Yes, true, the biological basis for the impairment of the pain, the individual's history, the patient's attitudes, beliefs, emotion, behavior, which are going to interact. We have to pay attention to the coping, support, financial resources available to that person. It's not just a broken body part. It's how this person has a context to live in, response by significant others, and the context in which the person works, and the social and economic influences available. So if a treatment is only modestly effective, last slide, what we need to consider and what can be done is we need to create and evaluate strategies and encourage more realistic expectations for symptoms and treatment. What can we realistically and appropriately expect? And what should the patient expect? We need to maximize the therapeutic effect of the caring clinician. All the different treatments that you saw that were non-pharmacological are all based heavily on an interaction between the patient and provider. And that caring clinician, that non-specific effect, if you will, is very important. Determine how best to facilitate, encourage, and motivate patients for self-management in the absence of cure. Develop and evaluate timing of treatment prevention of misuse and disability. Develop and evaluate new treatments, obviously. Develop treatments that address patient pain morbidities. Determine what works for whom, not just what works. Evaluate combination of treatments and investigate strategies to facilitate maintenance and generalization of treatment benefits and relapse prevention. If, in fact, we didn't cure people, they've got to do these things. How much they're hearing is another issue, but we need to have people doing things over long periods of time. I'm sorry I went 2 minutes over, but I will give it back to you. Thank you.